cervical cancer too. This is for areas challenged by less resources than what we've been talking about. And this is extremely important, and obviously for much of the world where cervical cancer is such a burden. And so for our chairs, we have Rolando Herrero and José Jerónimo. Rolando works for Guanacaste. Who are you with now? Oh, of course you are, IARC, yeah. I looked at the last paper and I saw the Guanacaste project on there, but of course you're with IARC. And then Jose's still with PATH, and I think you know both of them. They've both been very important in trying to bring screening and prevention to countries with less resources. So we'll start off with Jose, is going to be the lead-off speaker.
Okay, thank you. Well, I think that the session is going to cover several of the aspects of working on cervical cancer in developing countries. Many of the people here in the room, I think, have experience working in cervical cancer in different areas in the world. Probably some of the things I'm going to mention today are familiar with some of you. But I would like to have a worldview and brief description of the main challenges I identify. As a background, we have a huge challenge, a huge population that we need to target in order to avoid the still very high number of deaths that are happening every year. Most of those deaths are in developing countries. If we look at the population that are recommended to target by the World Health Organization or many of the guidelines in developing countries, that is women 30 and older, we have that more than 1 billion women in the world are in that target age. That means that we have a huge challenge to reach all of them, or at least majority of them, in a 5 or 10 years period. The coverage screening in most countries is still very, very limited, less than 10%. That's why we don't have any impact in the cancer mortality. And the limitations of infrastructure in developing countries is very evident when we visit those places, and the challenges are not because the infrastructure happens in the where the population lives, like this picture in Uganda, or this other picture in India, or this other picture in Nicaragua. You see very familiar, all of them are very similar conditions wherever you go, very limited resources, and the same is translated when you go to the health facilities. That means that the resources we have in the country we are targeting to work is really limited. We are working with the countries in this range of the capacity of the income of the country for investment in health. That's why we were working in different options for cervical cancer prevention. The two most common options are visual inspection and the new molecular testing like HPV testing. Visual inspection, there are many years now of experience working in visual inspection, more than 10 years or 20 years in some countries. Now it seems as a very good option to start with, but after those many years working on visual inspection, we have that still in the map in the world. There are very few countries working with it, and there are in those countries the visual inspection is available in very few areas. That means there is still a lot of work that we need to do there. And the other option is HPV DNA testing, and the situation is very similar. HPV DNA testing in Africa, only we have as experience as a pilot our work in Uganda. There are other pilots around the continent, but there is no program implementing HPV testing. Rwanda is starting soon with a donation of Care HPV, but that's basically the only country where we will have a more implementation of HPV testing. What do we have now? Basically, very limited or no screening in all of most of the developing countries. We have Papa Nicolau is still a problem because still many doctors in developing countries think that Papa Nicolau is the way to go. There is a lot of need for education. Every time we go and talk with doctors, they still keep trying to go back to Papa Nicolau as an option. We show evidence to all of them. I just coming from Peru from another meeting, when we discussed also these issues about Papa Nicolau, and still the questions from the audience were around that. Why don't we go and implement pap smear? And we see that it doesn't work. We really have evidence showing, for example, in Nicaragua, in our experience, the sensitivity of pap smear is 39% with no quality control system. And even in countries where the quality control for Papa Nicolau for pap smear is better, the sensitivity doesn't change, it's even worse. In Chile, have a better quality control system than Nicaragua, and the results are still very poor. I mean, there is no way to continue going in that direction. Visual inspection have a better sensitivity than pap smear in most of the countries where this test has been implemented. The challenge is that the sensitivity is not optimal, it's still around 50 or 60%, and suboptimal specificity. But it's a good option to start with. The other is HPV testing. We know it's much better sensitivity than visual inspection of pap smear. It's feasible to use this testing with self-collected samples. We have evidence from India, Uganda, and Nicaragua showing that self-collection is very well accepted, and the results are better than visual inspection or pap. It's feasible to run in facility with very limited conditions. Now working in the same countries, in areas with extremely limited conditions, in some of them with no labs, and the test was run in a storage room, basically using electricity and a table where we put the equipment, and that's it, no real labs. The results were really good. The specificity is still not optimal. And the question always when we talk about HPV is, okay, do we need really visual inspection? Why should we work with visual inspection? In the last FIGO meeting, one person, very smart person from Senegal, asked me, okay, I have a few dollars here, and I was planning to start with visual inspection, but now after listening of HPV testing, I think I should start with HPV testing. But I think that in areas where you have no capacity for pelvic evaluation, no experience for pelvic evaluation of the cervix, you need to start to create that, and visual inspection could be one option, because you have to have something to offer to those women who are positive in the HPV testing. If you do HPV testing, there is nothing there to evaluate the positive. Our experience in one of the sites where we work is that the results at the end are very bad. We did a study with HPV testing, care HPV specifically in 3 countries. This is in Hyderabad, this is in India, this is Uganda, this is in Nicaragua. Very limited conditions, public services. Look at the clinics here. The clinics are very limited, and the results were really good. For care HPV, cervical care HPV in Uganda and Hyderabad were really high, almost 90% in both. In Nicaragua, around 80. Self-collected care HPV a drop in the sensitivity. In Delhi, I think this is a good learning, because in that place, the capacity of the partners there was very limited compared to the other sites, very limited. And this was a demonstration study. That means that we didn't intervene that much there. And the point is that if we don't have good capacity in the ground for reaching patients, for doing every one of these procedures and evaluation of the patients, pelvic evaluation, everything in good conditions, we are going to have bad results whatever test you implement in there. What are the challenges? Basically, I just put here some of the challenges. I think one of the big ones is making the change to new screening options. In some places, doctors are ready, they know that they can make the change, they can start with new options, but making that change, there are some factors that are limiting that. And the other big one is training of providers. There are others there, but I'm going to talk a little bit about these 2 that are the biggest ones. For making the changes, I think demonstration projects are very helpful. We completed this demonstration project in Nicaragua. The government now is planning to change to care HPV. They have the evidence, local evidence, and the countries in the region. El Salvador is starting also a project with care HPV, implementation of care HPV actually, and the other countries, yeah, looking at that evidence in the region, it's much easier for them to make the decision to start with another option. Education of key opinion leaders, this is critical. Every time you go, still they attach to all options. Technical assistance for implementing new alternative. They have the willingness to do the change. They have some of them the resources to do it, but they need guidance how to create a good program to implement these new options. And costing evaluation. The question always is how much cost each one of these alternatives. Visual inspection is very cheap. HPV testing is more expensive. What should I use? And we did an evaluation study in Nicaragua where we calculated the cost per case detected and treated in those conditions, in those provinces. And we saw that for visual inspection per case of CN2+, detected the cost was $924. And for HPV, vaginal or cervical, the cost was lower, because you are detecting more cases with these two alternatives. Visual inspection, there are many positives, there are really no cases, but you have additional cost for the follow-up of them, and even treatment of them. And this is very powerful evidence. We presented this in Nicaragua, and was a great tool for the Minister of Health to look at that and start to change completely the way they look at the program they had. The other is training of providers is still a challenge. There are many options. There are new options to implement in developing countries. There is more confusion. Providers, they don't know what to do. There are several options. What should I do? And they refuse some of the new ones because they don't know them. That's the point. And that's why we work with the National Institute in Peru, National Cancer Institute in Peru, and JAPAIGO to create a training excellence center in that country that was a huge success. Now we have providers there implementing cervical cancer programs around the country, and they went later to Nicaragua and also to some part of Bolivia and Colombia. And now, for example, with this capacity, they went to Nicaragua, created master trainers, and now the government in Nicaragua is training hundreds of providers in these new approaches for cervical cancer prevention. I think it's a great tool to create capacity there. This is the model. Basically, the Cancer Institute in the country, or the referral center in the country, working with the hospital and health centers, create networks of providers with several different capacities. Here in the health centers, in the lower level, whatever is available, visual inspection is the option, can be implemented here, and even cryotherapy. Those cases that are not eligible for cryotherapy here have to have a referral center, a hospital where they can be managed, or the Cancer Institute in connection. I think the experience in Peru has been really very good. It's a good model to follow. Funding required. Funding that is required is very different per country. It's very, very different per country. There are countries where they really need funding for infrastructure because the basic infrastructure is not available. But there are other countries where it's more to facilitate the introduction. They have money, they can buy new technologies, they can do the change, but they need only the guidance to do the change. I mean, the amount of money and effort you are going to expend in one country depends on the situational diagnosis you do at the beginning there. Now we have new updated guidelines that are also very helpful. The World Health Organization is coming with a new set of guidelines that are going to be hopefully published by March 2013, where we see that the new options like visual inspection and HPV testing are there. And that's a huge tool to use, because if you see the current guidelines from WHO, the only option that is there so far is pap smear. Now with the new ones, the other HPV and visual inspection are mentioned as good alternatives to work with. In conclusion, we have more options for screening and treatment than 10 years ago. That's great, but also creates a challenge for training providers. Different screening options can be implemented in different areas of the country. One specific country have to select different strategies depending on where in that specific country you are working. It's going to be very different in cities. It's going to be very different in the provinces. Still need for introducing new alternative, but now it's the mind of doctors and decision makers are much more open. It's much easier now, but there is still the need for support. And this is clear, no need to wait for more studies. I think we have enough studies. We have enough, and now it's time to implement these new options. Thank you.